This conference will now be recorded.
Hi, we're going to spend a little bit of time talking about the dietitians and their role in PDPM's NTA methodology. There are three specific areas I want to address in this education. All three have the potential to increase revenue under the non-therapy ancillary or NTA component of the Medicare payment. When you are looking at this PowerPoint presentation, you will notice that there are several items that have underlined, and these all indicate that there is a link attached to these. And if you were to click on them, you would be able to open up several different documents that you can use that I will also include when I share this information with you. This first particular one happens to be demonstrating for you the NTA ancillary therapy components of the PDPM system. And as a bonus, IV fluids that are administered in the hospital or the facility is going to increase the nursing component as well. And we'll provide more training for these other components, and this is specific to NTA right now. So we're talking about morbid obesity, which captures one NTA point if we have an ICD-10 that's coded in the MDS. So although the MDS coordinator is the person that is entering this information, they're going to get some of that information using the medical record, including the dietary notes. Morbid obesity is defined as 100 pounds over ideal weight, more appropriate to consider an ICD related to excess calories. A BMI of 40 or more, and there are 5 additional ICD-10s that qualify us for these BMI-related obesities, and a BMI of 35 with the presence of an obesity-related health condition. So although someone's BMI may not be 40 or higher, if it's 35, if they have things such as high blood pressure or diabetes, again, we would be able to define them as morbid obesity through the communications with the physician and use the ICD-10 that has them as morbidly obese related to excess calories as opposed to related to their BMI. Again, here is a link that is here that would bring you to a BMI calculator. So if you were looking at this PowerPoint and clicked on that, that's what you would be able to access. Malnutrition, or the mere risk of malnutrition, also captures an additional NTA point with a simple check mark on the MDS at section I-5600. They put a check mark there for actual diagnosis that we have, or the risk that has been current and active in the last 7 days. So for example, the protein calorie malnutrition, or PCM, they tell you that the prevalence of this varies depending on the setting we're in. So it's about 4% estimated out in the community. And once they get to a subacute level, then that's 29% of people that are representing a risk of malnutrition or an actual diagnosis. And then 27 to 38% once people are hospitalized and they're elderly, between 60, 79, age 80 and older, it may go up to 30 to 40%. And they're looking at people that have been hospitalized for a couple of weeks. So there's definitely potential within our population to identify the risk, if not the actual diagnosis of malnutrition. The Journal of Academy of Nutrition and Dietetics would say to you that although malnutrition can occur at any BMI, individuals at either extreme can be at increased risk of poor nutritional status. And it's telling you again, even overweight or obese adults who develop a severe acute illness or experience major traumatic event are at risk and frequently need and benefit from intensive nutrition interventions. So once again, if you were to look at these things, there are links that are going to bring you to several different resources that you're able to open and justify some of the things that I'm telling you here, so that you don't think that I'm just making these things up off the cuff, or that they are strictly driven to for a reimbursement sort of opportunity. IV fluids, while a patient is a resident, will capture 3 to 7 points for NTA with the check mark in Section K. So you guys do Section K on the MDS. If you hadn't been previously, the expectation is that you do that now. So when you put a check mark that someone's received IV fluids in the past 7 days, you are adding to the value of being able to do this NTA and increasing that based on the caloric intake of those IV fluids. So this is just a graph that again comes from one of the different resources that we have available from dietary journals. And according to the agingresearch.org, up to 85% of individuals in long-term care experience malnutrition in some form, with the risk factors being loss of appetite and confusion, decreased urination. So when people are not voiding as much, many people are not associating that with the potential for it to be a malnutrition. Inadequate intake, loss of muscle mass and body fat, things that dietitians would be aware of, therapists might be aware of, reduced hand grip strength, localized or generalized edema. Here again is a link for chronic malnutrition, and it's giving you that information as well. Also talking about some of the lab works and nutritional intake and when you should be looking at those things. So use the resources that are within this PowerPoint to help you in making these decisions when we're putting this in our documentation and or coding the MDS. The presence of 2 or more of the above characteristics are necessary for the actual malnutrition diagnosis. So when you have 2 of these things, yes, we can indicate that they're at risk, but to support the record even more, we could address the doctor with these changes and discuss with them the potential for an actual malnutrition diagnosis. You would also want to consider these things when you're looking at risk. Does the patient have broken or decaying teeth or poor fitting dentures? Are there dexterity problems such as arthritis and decline in functional ability? Multitude of their disorders, so they have a lot of comorbidities and medications that they take with these things that may be causing and putting them at risk for malnutrition. Presence of infections, drug interactions, diseases such as cancer or cirrhosis, end-stage liver, wounds, added supplements. So we're giving these people fortified meals, or we're giving them mighty shakes or any of that sort of stuff. And the percentage of their meal consumption. Look at the record as a whole and come to the determination if indeed this patient is at risk for malnutrition. Even people who are taking in 100% of their meals could still be malnourished. So when you're looking again at this is malnutrition in older adults. It's talking about a hidden epidemic that is here. 35 to 85% of older long-term care residents face malnutrition. If you were to click on this picture, it's going to take you to a 5-minute video that is related to this, and you'd be able to watch that at your leisure. So this is undernourished, is considered underdiagnosed, and definitely being undertreated within our environment. So it's up to us to get this diagnosis, to get these treatments, and to get these patients as nourished as possible. Again, telling you that any body size or type can be malnourished. It can occur, again, at any body mass index, BMI, but whether it's at one stream or the other, increases the risk of poor nutritional status. Although this education was specific to recognizing and supporting malnutrition, morbid obesity, and IV fluids, there are several other opportunities for dietary departments to support a skilled stay and optimize the PDPM revenue based on your expertise, your observations, and of course, your documentation. Once again, clicking on a link that will open up a series of information for you to be able to use and consider as you're creating dietary and nutritional services. This is a note, a guideline that is put forth by the ANAC. So you'll see here that's the ANAC learning community, and it gives you some information about what we should be including in our documentation. There's opportunity for NTA points for tube feedings, NTA points for the diagnosis of diabetes, When we have mechanically altered diets, that impacts the speech component. Symptoms of swallowing problems impacts the speech component. And then your recognition during your medical review and your awareness of renal situations and cirrhosis, which is an NTA point, pancreatitis is an NTA point, end-stage liver is an NTA point. And then there are several other GI diagnoses such as inflammatory bowel disease and Crohn's that can get additional NTA points. You don't necessarily need to remember all of these things if in fact we just make sure that everything that's appropriate for the patient through their medical history and through current documentation is reflected in your notes as well as in the MDS. Here are some examples of malnutrition or risk for malnutrition opportunities that were recently identified in some of TRIO's EMRs. A patient who was 94 pounds, pureed diet with thickened liquids, receiving a magic cup, recent weight loss in November, currently positive for COVID, and had a urinary tract infection. All things together, looking at that, I would indicate that this person is at risk for malnutrition. A diagnosis of COVID, dementia, dysphagia, a 6% weight loss in 1 month, significant weight loss documented as thin and frail. Now, this patient has no dietary assessment in PCC for this time frame. Are you, as a dietitian, being made aware of residents that they are changing their skill level so that you can contribute to supporting the skill? Everyone knows when someone's admitted to the facility and enters, and yes, they may be Medicare or they're not, but have you been told about the people that we are skilling in place when they test positive? And so now there's a new MDS that needs to be done. And of course, there should be new documentation around that assessment that contributes to the patient being on Medicare, as well as optimizing the revenue for that stay. This patient was also diagnosed with COVID, has dysphagia and dementia, and had significant weight loss present. They're on a pureed diet and they're getting snacks and supplements. There's been a change over the past week of their meal consumption. There was, again, no dietary note for this skilled time frame. You should now be doing Section K of each of these MDSs, which would make you aware of the fact that the person has an assessment for some reason or another. And I would anticipate a note that is on or around the ARD for that skilled patient. COVID positive, dementia, swallowing disorder, a nutritional eval on November 15th, and a care plan that the average meal intake is 25%. They're on a pureed diet, they have fortified foods, they're getting supplements, they're confused, and weight change is expected, all according to a very well-written nutritional eval. Okay, so then we have all of this information. They are definitely at risk for malnutrition. We should take credit for that, and we should start to see those words in your documentation. So they meet the criteria for the risk. You just need to add it to your documentation when it's appropriate. Would be a more extreme situation. This person, we added an NTA point because of malnutrition, right? This actually changed somebody's score for NTA from an E, which was $74.84 a day, to a D, $103 a day. If you know anything about PDPM, the first 3 days are paid at 3 times the amount. So this would have actually been a difference of $60 a day for the first 3 days of the stay, and then $20 a day each day since. It's a lot of money just for coding risk for malnutrition. Diagnosis of dysphagia. They had COVID. They've had their diet recently downgraded to puree. They get a magic cup. They're on weekly weights. All of those things are indicators of them being at risk for malnutrition. In addition, a speech note dated 11/22, which was within the time frame, identified buccal pocketing, which also increased the speech component from $83.45 to $103, an additional $20 a day. So now we're up to about $40 a day increase in revenue for this patient. And there were several patients in the same facility over the last 2 weeks. That's a lot of money. All right, we need to make sure that we are using the notes, we are using the medical record, and that we are looking at every opportunity to make sure that we're being reimbursed for the care that these patients need. So the nutrition note that was in place for this patient looks like this, though. We dashed out the nutrient needs, right? We only put down their fluid. Does the total nutrition intake meet it? We said yes, and then we put nothing else in here. This was a completed note, and we did not even finish it. This is not appropriate, okay? We need to make sure that everything that we're doing for this patient from a dietary standpoint is put into these notes and adds value to the medical record. If this medical record went out right now and it gets pulled automatically through PCC, we set it up, blank data is going to be going with this medical record. That's a poor reflection of the facility's awareness of the patient's needs and how we develop a plan of care based on that. We look at marketing, and people think about marketing and being able to go to hospitals and sell our services, and to, assisted living groups and sell our services, and we want insurance companies to have people coming to us, and then we send documentation that looks like this, and that's a poor reflection. This is where marketing starts. It starts with our medical record for all of the people outside of our direct influence that are going to be seeing this. Home health agencies get this information. Insurance companies get this information. Hospitals might get it. Lawyers might get it. All kinds of people get it, and you don't want blank documentation making their way to them. So again, make sure that we have documentation that improves the ability for MDS to capture the qualifiers, improves resident-specific care and care planning, and increases a support of a daily skilled need and reimbursement at the appropriate level. You are a very, very important part of this team. Please make sure you're part of the conversations related to capturing these qualifiers in an effort to improve care, outcomes, and reimbursement. And please take the survey related to this education. Thank you and have a good day.